This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. I'm your host, Vanessa. I'm here with our producer, Seth, and of course, Mr. Not Your Doc himself, Dr. Charles Tadros.
Hey, good morning, everybody.
We are very excited about today's episode. We've got another clinician friend here of Dr. Tadros's, Dr. Larry Shapiro.
Yeah, of our whole office. Everybody's met him.
We're huge fans of Dr. Shapiro. I'm particularly excited to have you here today. Dr. Shapiro is our very first talk therapist on the pod.
Yes.
We reference therapy a lot, and we're super excited to hear your point of view.
I'm glad you invited me.
Yeah, absolutely.
So thank you, Larry. Dr. Shapiro actually came to our attention, his work actually from, I guess, Dr. Luis Jufra. Dr. Jufra is a psychiatrist here in town, and has known Dr. Shapiro for many, many years. And Dr. Shapiro had worked, and he's going to fill us in on some other things because he has such a extensive background that plays into why we have him here today. Mm-hmm. He has so much experience, clinical experience, that he was at St. Louis Behavioral Medicine Institute, where I refer a lot, and then now he is at Quantum Behavioral, where he focuses his practice on veterans, military veterans with PTSD, especially that require other special treatments, including psilocybin. Well, eventually it'll be psilocybin, hopefully, but right now for ketamine, and so that we work from a ketamine clinic. So Dr. Shapiro came to us just talking about common patients, and so thank you for joining us today. We're not going to quite talk about ketamine and stuff like that. We'll do a little bit towards the end, but we want to talk about your extensive clinical experience because I think that's where most of our patients and most of our clients, and I think our hearing audience, would like to know about. A lot of stuff happens one-on-one behind closed doors, and a lot of people need therapy, but you do it kind of special, and we appreciate that. I think our patients appreciate that, and I thank you for coming.
It was a pleasure. So, whatever questions, fire away.
Sure.
Absolutely.
Dr. Shapiro, anytime over several years, if I have a patient that is seeing mental health professionals and I ask them what their diagnoses are, or if they're seeing a therapist, a talk therapist, a psychotherapist, what are the short-term and long-term goals are. Oftentimes the patients don't know their diagnoses, or certainly are incomplete or inaccurate, and certainly really don't know the short-term and long-term goals of talk therapy. Can you kind of explain kind of what psychotherapy, I call it talk therapy, and kind of how people get into it and what they should be looking for a good therapy?
Sure. Well, first, let me just address the diagnosis part and the goal setting. A lot of times, the diagnosis is there really for insurance reimbursement.
Right.
Mm-hmm.
Yes.
Right.
So if you've got therapists who don't take insurance, then a formal diagnosis becomes almost irrelevant to them. They're just treating them for whatever the symptoms are. Mm-hmm. So it wouldn't be unusual to not have a diagnosis. For me, I'd like to at least conceptualize.
Right.
Here's the diagnostic problem that we're dealing with, because that's going to lead my treatment in terms of how I think. But, if someone is coming in with a primary complaint of hopelessness, it doesn't necessarily mean that they have major depressive disorder.
Sure.
Yes.
So a lot of times the complaints that people have don't fit neatly into the DSM categorization. So sometimes just diagnosis becomes problematic. Because it doesn't fit neatly. And the
DSM is the Diagnostic and Statistical Manual for Mental Illnesses or multiple.
Right. So that basically it's our workbook.
Right.
It says, or a reference book, here's your cluster of symptoms.
Right.
What
This is how we'd categorize you. Yeah.
Yeah. So, but even now for most insurance, they're using ICD-10.
ICD-10, yeah.
So, but just trying to come up with a diagnosis for a lot of people, in most cases, it's really based on what you're wanting, what kind of symptom relief you're wanting, but you might not fit into cleanly or neatly into a diagnostic category.
That's right. I tell people the same thing you say. Just because you can't focus or remember doesn't mean you have ADD or ADHD, et cetera. And it's that's, I think, is a big deal. Thank you, for clarifying that.
So then, in terms of goals, what is it that the person's coming in with? When I was in graduate school, the question that we were told to ask is, so how can I help?
Mm-hmm.
Then for me, it evolved in, well, how can I help? That puts all the responsibility on me.
Yeah, right.
To do all the helping.
Yes.
So then the question became, what can I help you with?
Mm-hmm.
So now there's a shared responsibility to now, and this is kind of an outgrowth of my work with psychedelics, in kind of understanding therapy even more deeply than I did before, was how do you intend to use psychotherapy?
Mm. I love that.
Yeah.
Which is a very, it's a very subtle paradigm shift. Right. But the implication is you're going to use this.
Right.
You're not going to sit back passively.
Yeah, it's a tool. It's another tool.
That dovetails beautifully into, a big question that I have for you, which is, what is the work of therapy? A priority in our conversation today is to help people who are listening to this really understand what their role would be in a therapeutic relationship and how, exactly what you said, how they're going to use psychotherapy. So what is the work of therapy for on the patient side or the client side? And is it an active or a passive process? Is it something I just show up and expect to be fixed, bathed with your knowledge and wisdom and sayings? Or is this an active participation on my end to get benefits from?
I like to think that I'm brilliant, that a couple of words will cure.
I love it. Yes.
That would be wonderful. So a lot of people come into therapy, their primary or initial or only experience is what they see in the movies and on TV.
Yes.
And what they see in the movies on TV is you sit and you talk about how horrible your life is. And then the therapist nods their head and says, that must be very hard for you.
Right. Or how does that make you feel?
How does that make you feel? And frankly, actually in training, that's a lot of it because especially me, having been in graduate school in the 80s in the Bay Area, a lot of it was, still based in this kind of grounding in psychoanalytic psychotherapy, which is a very passive, for a therapist, a very, very passive.
And a very long-term, multi-year. A decade.
Decades sometimes.
Yes.
And so my dissatisfaction with that type of approach started in graduate school. Because I was like, holy cow. I just have to lay there because you have to go through it. Also, when you're in graduate school,
that's right.
Let's have you go do something.
You become a client or a patient.
What am I doing here? Yeah. I'm just talking off the top of my head.
Right.
It's not really doing anything. So what people see in their first experience is through popular media, which is a very, very passive approach based in this passive approach that we were taught in graduate school. This is what therapy is. You talk in this kind of stream of consciousness. Eventually, you'll develop an insight into the problem that you're coming in with, and miraculously,
you'll stumble upon the aha.
And it goes away. And my job is to just sit there, literally almost guide you, but not too much.
Too much, right. You can't do it too much, right. Can't give you an answer, right.
Right. So I ended up eventually, I was not really happy with the training and the whole philosophy, that philosophy. So I did a postdoctoral fellowship at SLU on their behavioral treatment unit, which was, at the time, it was great. It was the only mental health inpatient unit run by psychologists with the help of nursing staff. We had a psychiatrist, but everything. These were treatment-resistant obsessive compulsive disorder, panic disorder, agoraphobia. People would come from all over the country. There was also a time when we could keep people in the hospital for 30, 60, 90 days.
Right.
And we could really do great work over that period. And the nice thing about that was it was directed. Right? You have OCD with contamination. We're going to take you out and do exposures for contamination. We're not going to allow you to wash. And then you find out, it's like, holy cow, these people are getting better.
Right.
But I want just a second. I want everybody just to pause because the stuff that's coming from Dr. Shapiro's lips is gold. This is the stuff that we deal with at a micro level, nothing like that. But what he just said about exposure and response therapy, extinguishing people who are so OCD that they can't finish a meal. They can't even, there's nothing. They're so stuck. They're frozen.
They're so stuck. They're like some people, look, they are, let's say, functionally anorexic.
Right. Yes.
Because they can't, let's say they take a fork and put it on the plate, but because of a thought,
right,
they have to repeat it until it's good enough. And so you keep repeating it to the point where you can't actually take a bite.
Can't eat.
So you become functionally anorexic. So you might be misdiagnosed as having anorexia when it's really
an OCD.
An OCD issue. Where people would come with bloody hands, right? Because they're washing so much. Not just washing, but maybe they're using steel wool to get the contaminants.
Sure.
So we would get that level.
Yeah, the most severe, obviously.
The most severe.
Right.
But we could do these treatments, exposure and response prevention, in a controlled environment, right? So if someone, a worst case scenario, especially in the winter, is in the shower and they don't feel like they're getting clean enough, well, they'll end up in the emergency room with hypothermia.
Yeah, right.
Because they're in the shower for 5-6 more hours in the middle of the winter.
Yeah.
And they've got hypothermia. Well, we can bring them into the unit. We can take the knobs off of all of the sink and the shower. It's like, you're not going to shower for the next 30 days.
Yeah.
We'll give you water to brush your teeth.
Right.
Washcloth to wash up, a little bit. But that exposure to contaminants and then preventing them from their typical response or compulsive behavior, I mean, the research is pretty clear. This is what works.
Right.
And this is not, and you had medications on board, you had psychiatry, but the focus of the whole unit was behavioral modification through these techniques.
Right, because the people that got there, they were not responding to medication.
They had failed medicines, right.
And even people who were having brain surgery, like a bilateral cingulotomy, they're still, you have a brain surgery and you wake up and you still are symptomatic.
Yeah.
So these are, some of the people that we deal with. So for me, it was a real eye-opener that if you took a more active approach to these problems, people actually get better.
Right.
Forgetting like the time frame, they just get better as opposed to sitting around, listening, waiting for them to get better.
Right, exactly.
Now we can actually do stuff that's based in research, based in experience, and if you just do it, it works.
Yep. And although these are the most severe, this also translates to much milder illnesses that we see as outpatient.
Absolutely.
And that's I think that's certainly the take-home message for our.
Right. So when you talk about, so what's the work? I tell everybody, a couple things when they come in, that especially people say, I just need to learn how to cope with whatever it is.
Sure.
My first response is, that's not good enough. Coping implies you will continue to have this problem.
Sure.
Right. Barely holding on.
Right? So you set the bar too low. Right. The goal for therapy has to be the elimination of the symptoms, not coping with the symptoms.
Yeah.
So not a response, but a remission. Not enough to
remission
have a response.
or cure. Mental
I don't
health
think I'm going to tell you, and you know this already. Nobody talks remission or cure in psychiatry.
No, never.
We barely talk about it in diabetes, let alone severe mental health issues. Yeah.
But for me, you have to set up the expectation.
Yes, that's right.
There's the potential for you to be good,
free of this,
to be rid of it.
Yeah.
That these are symptoms of an underlying problem. And if we can actually work with that, you don't have to live with it. Yeah. And a lot of times people will integrate, when I say they integrate this pathology with their personality. It's like, well, I've always been an anxious person.
Right.
Well, as soon as you say you're an anxious person, now you've integrated a pathology
into
with your personality.
Yeah,
and so now you can't
reject you can't reject yourself. Right.
So now part of the work is like we have to separate mentally. This is a pathology that doesn't belong there, like a bacterial infection. And then you've got your character over here. We need to separate this, so that might be part of it. But it's also setting the expectation that between each session, you're going to have work to do.
Yeah.
And so some of them might be something as simple as if I know someone's coming in because they've got some issues with confidence.
Confidence.
Well, I know when people suffer with low confidence, low self-esteem, I know that they overuse the word sorry. And they've probably been told over the course of a lifetime, stop saying sorry. So my thing is, this is an actual homework assignment. This isn't me just casually telling you to stop saying sorry. Your homework is eliminate the word sorry from your vocabulary when you're talking, in your text messages, in your emails. And when people do that, when I explain, it's like, look, every time you say I'm sorry, you're basically telling yourself that you're guilty.
Right.
Because sorry implies guilt.
Yes.
But you didn't do anything.
Right.
Just reinforces this idea of guilt.
It reinforces the idea, absolutely.
Right? Yeah. So let's get rid of the word sorry. You say excuse me, pardon me. I apologize,
Gotcha.
which are appropriate, but not sorry. And people will say after a week or two or a month, because it takes them a while to really get a hang of it because it slips out so often, that they find that for some reason their confidence is starting to actually improve just by eliminating the word sorry.
Yeah.
Now that's a very simple homework assignment,
Right.
but hard for a lot of people to do. Or I notice that when we're talking about really serious subjects, you're smiling and laughing. Cut it out.
Yeah.
Just cut it out. And I say that, and I will say, you got to cut it out. And then we'll say, well, okay, so that's kind of a light approach. But then to say, well, we have to be able to match your expression with the content. Because how are you really going to address this issue if you're laughing at it?
Right.
Because that means you're not taking it seriously. So how do you expect anybody else to take it seriously if you're not taking yourself seriously? And once you call people on the mismatch,
Right.
some people will just start crying spontaneously.
Wow. Yeah.
Because no one has really forced them to look at that. So these are little homework assignments. They're not huge.
Yeah.
But enough where there's a subtlety in change of behavior that will also change cognition because it's a correlation. It's cognitive behavior. I practice cognitive behavior therapy, CBT. So the idea is if we can change your thoughts and your behavior will change. Sometimes it's just easier to change a behavior.
Yes.
And if you change the behavior, the thoughts get pulled kicking and screaming to match the behavior. So you stop saying sorry, the attitude changes, even though we're not necessarily working directly on the attitude. We're just kind of taking a roundabout.
So what Dr. Shapiro said essentially is that people can go for decades in these behaviors and that are not helpful, and literally within a few weeks, a few months of some of these not very big cognitive behavioral treatments and homework, change a whole lifetime's worth of behaviors that were not helpful. Dysfunctional.
And I think he's reinforcing that by saying that if you don't engage in the process as the client or patient, you're not going to make that transition, right? Have you ever had a patient or a client experience, extinguishing of whatever that symptom is without actively engaging in that process themselves and doing the homework, doing the work?
No. No. I mean, and because then that comes up at some point. To say, hey, listen, are you really in a position to utilize therapy?
Yeah.
I understand it's hard.
Right.
What I'm asking you to do is hard. So it might have to be going through and say, well, what is making it hard for you to do this? If you know intellectually this makes sense, what's the holdup?
Yeah.
So then we have to look and see, well, what's going on here? And that might mean, are there things going on at home that we haven't really addressed? Is there a childhood history that's connected to it that we haven't really addressed just yet? Are there expectations? So if you expect yourself to always fail, well, and you've been like that since you were a kid, and that's been reinforced for the last 30, 40, 50 years, yes, we can get some symptom relief through a couple of simple things, but if you've never really thought about these connections and say, well, that was then, or understanding coping strategies. We understand that, you grew up in an alcoholic household or a household where there's abuse or neglect. As a kid, you develop coping strategies to get through that.
Dysfunctional or not, to get you through life.
And at the time, I'll say, look, at the time, functional.
Absolutely. It saves you.
The problem is then you take these coping strategies from childhood and you apply them in adulthood, but the context is no longer there. And so what had been adaptive is now maladaptive.
Right.
Kind of working with combat trauma. It's like you learn to be hypervigilant and hyper-aware to keep yourself and those around you safe.
Protects
but
you.
when you do that in a civilian capacity, it becomes incapacitating sometimes because now you're looking at everything and everything appears to be a potential threat.
Yeah, it's a threat. Right.
I think that dovetails beautifully into the next thing that we kind of wanted to bring up, which is that your current work now, working a lot with people with PTSD, combat veterans, and I think specifically for this group of people that are taught so much to take care of the person to their left and right, to be vigilant, to be strong, to have the solution all the time. I'm wondering what it takes to help convince some of these people to engage in the therapeutic process when there's so much stigma in our world, again, from TV and movies about, getting therapy, that if you can't deal with this privately and personally, there must be something weak about you or broken about you. So how do you meet people and convince people that this is a tool, this is a survival strategy, this is a technique and a skill as important as any that they learned, in the service?
Well, with regards to the stigma, I think, what's interesting to me is in the military community, especially if you're near a VA, people know there's treatment there. They just don't like it.
Yes.
They don't like the VA. They don't like the process.
Right.
So they know it's there. I happen, because I've been doing this for a while, I've developed a reputation in the area. So people say, hey, you've got a problem, go see Shapiro. If you don't want to go to the VA, go see Shapiro. If you're not happy with the VA, go see Shapiro. So there's a network.
Yeah.
What's interesting is, to me, the veterans, it's kind of almost acceptable now to go get treatment for PTSD.
Good.
The group that is out there with no help are first responders.
Yes.
That's a group that I see very infrequently. Rarely. There's only one fire chief in the area that actually has referred over the last 10 years, maybe 2 people.
Wow.
But I never get referrals from any police departments. I don't get referrals from EMS, don't get them from fire districts, but I'll get referrals for veterans.
Wow.
So even for first responders, there's even more of a stigma.
I mean, I have a CSI, a former crime scene investigator, severe PTSD. I've had other people come to our ketamine clinic. Yes, they're first respond. They're digging out bodies and burnt bodies and smells, and it's just as bad.
Incredible.
It's just as bad as some of the military things that we've heard about.
And it's repeated, and people don't realize.
Right.
They think about.
Right.
I think most people, again, from TV, unless they're watching,
Right.
SVU. Most people's experience with the police and fire department is, here's a traffic ticket.
Yeah.
Right.
Or here, we'll look at your cat, or we'll rescue you for something. They don't realize how many suicides they respond to.
Yeah, that's right.
What do they experience when they respond to a car accident?
Yep.
Yeah.
Child abuse.
Yep.
Yeah.
And it's repeated.
Right.
Over and over and over. So with a combat veteran, in a lot of ways, it's easier.
Yeah.
Because we know they're not going to be redeployed.
Sure.
Right.
But with a first responder,
They go back. To
they've got to go back unless they
shift.
are going to retire.
Right.
From that profession,
Right,
do something different. And there's not a lot of empathy, not a lot of sympathy in the first responder community for getting treatment, for the recognition or treatment. So there's a lot more alcohol abuse, drug abuse. Dealt with police officers, got caught stealing narcotics. From an evidence just to kind of neutralize or numb some of the pain. So the combat veterans, there's more. It's more acceptable because people know, combat.
You go into a war zone, you leave your safety of your country, you go into a war zone, you know that you're in trouble, you have people around you, and you know that you're always on. The people that are first responders is different shifts of work. Yeah.
So with the warrior community, the veteran community, my work has really dovetailed or really came out of a reaction to the failed treatments at the VA.
Right.
And when I say failed, I mean like people dropping out.
Sure.
Because it was too intense, or they felt like they weren't being understood, or years ago when it was really hard, you have to wait, you have an 11 o'clock appointment and you're still waiting at 3 o'clock.
Yeah.
Yep.
And then you get really upset, and now they're going to, this person's been really upset, they're agitated. Now they're going to get put on a medication that's sedating.
Right.
It's not really treating the problem. The problem was they were frustrated because they had an 11 o'clock appointment and it's 3 o'clock.
Right.
So helping them understand the connection between their warrior mentality and their civilian mentality, the relationship between a forward operating base or a FOB, and how they behave on a FOB, and how they're behaving and kind of treating their house like a forward operating base, locking everything up, closing the windows, closing the blinds, having weapons distributed across the house, booby trapping in some cases. So being able to highlight, it's like, this makes what you're doing makes perfect sense.
Yes.
Right? There's perfect logic. And for most of the problems that people are coming to see me with, the behavior is perfectly logical. The problem is the rationale for doing it.
Say that again. Say it again.
The behaviors, what they're doing makes perfect sense. It's logical.
Yes.
If I believe that there's someone outside of my door waiting to take a shot at me, it makes perfect sense to close my blinds, to keep weapons, to protect my family.
Right.
All of that it's logical.
Right.
It's the original thought, the premise, the rationale that needs to be addressed.
That is incredibly powerful, and I think very salient for all kinds of maladaptive behaviors that we come up with, right? If we're, anxious in public, or, we deal with our depression by, canceling all of our responsibilities. The behavior itself seems logical at the time. I mean, we've even talked about this in relationship to suicide, that, can seem like a logical solution to a problem. That's incredibly powerful. Thank you for talking about that.
Yeah. So once you highlight all that for people, and also when you say what you're doing makes perfect sense.
Yes.
It's perfectly logical.
Yeah. Then people are like, oh my God, I'm not a crazy person.
I'm not crazy. Yeah. That's the first thing, right?
Right. It's a kind of normalize their reaction to whatever's going on, so that, because if you've got people telling you that you're sick, and you're telling yourself that you're sick, I'm saying, well, you're not sick. This is not right now. What we're doing is not really an illness like PTSD. It's like, I just said, look, it's not an illness. This is an injury. Right? You've been injured. It's like, when we talked, I think we talked about, like, during COVID, people worked in emergency departments and ICUs. People were perfectly fine right before the pandemic. Then you see all of this horrible death, lonely death, suffocating death. And you end up with PTSD on the other side of it. Do you say, well, these people are now mentally ill? Right. Or do you say they were scarred by their experience?
Yeah.
I think most would say they were scarred by their experience. So when I talk to veterans, I was like, you were scarred by your experience. You're not mentally ill. And for them, that idea, you're not mentally ill, you've been injured. Look, we can do brain scans, we can show the change in how what the brain looks like with chronic PTSD. We can look at the hippocampus, we can look at the amygdala, we can look at the prefrontal cortex. We know that this is the case, and there are very few problems. We say, look, this is, in the absence of exposure to trauma, you can't have this diagnosis. So this is an injury.
Sure.
And so then it changes the dialogue. It's like, this is in psychotherapy.
Right.
This is rehab.
Yeah.
And so when you talk to veterans and you use a rehab model, it's like, well, if you've blown a knee or you've hurt, people are used to physical therapy.
Sure.
They're used to rehab. So when you start couching therapy in terms of, no, this is rehab, not psychotherapy, it, again, destigmatizes the process of what we're doing just by redefining what we're doing.
I think that reframing is incredibly powerful and gives people a sense of agency and empowerment, that it's not some fundamental flaw in me, again, detaching it from the identity. That's incredibly powerful.
I mean, and I'm extrapolating, because you talked about the military, and the first responders, but for us, a lot of adults have had so much childhood trauma and the dysfunction that came along with it, that now they have a hard time at work and relationships and anger control, et cetera. And that is a type of kind of injury from your youth that you're bringing with you, triggered by whatever the triggers are and stuff like that. So that's the more common version that we see. Yeah.
And so again, along the lines of trauma, people, one of the things that I see a lot of that I'm not really sure why people aren't spending more time talking about it. There's a lot of media about bullying in childhood. No one really talks about is, well, what's the long-term consequence of that?
Sure.
So you're being bullied in elementary school, middle school, high school, but you're coming to me when you're 50 and 60. And a lot of that stuff that was going on then is still it's still driving. So we talked about those adaptive coping strategies, which is like, don't trust. Someone says that they like you, but then they turn on you. Right. Well, as an adult, and you don't trust people. No one, it's like, well, maybe that's a consequence of this history of being bullied that no one really took, but you're using that same coping strategy, just avoid, don't say, don't do anything, or be overly ingratiating to try to get people to like you. And then you're doing the same things in adulthood, and it's affecting your marriage, affecting your relationship with your kids, with work. Because of this now maladaptive coping strategy. So once you allow people some insight into what are they doing behaviorally that might be reinforcing this way of thinking or reinforcing these problems, you kind of have to lay out, for me, you have to lay out, here's what I see as the problem. in a more comprehensive way, in a way that
Yes.
they understand.
Yes.
Give them a framework to understand themselves.
Right.
And that's, I think, what gets missed a lot in traditional therapy is there's no framework.
Right.
So how can you establish a goal, short or long term, if you don't have a framework for what you're actually dealing with?
Right. Do you think, you chose to become a psychologist and not a psychiatrist. Do you think that psychiatry shares that sort of view with you? Do you think they're at odds with one another? Do you think things could be a lot better if there was more of a shared, kind of framework for helping people
plan.
functionally get better,
Years ago, well, first, let me just clarify. The reason I didn't go into psychiatry is because I hated organic chemistry.
Okay.
Good reason. And it was like, medical school is not for me. So I don't know whether or not I would have gone into psychiatry, but mine was like, my math and science skills were not, and I didn't want to put in the effort for medical school. So I took this route to be able to help people. I can't remember when it was, but it was years ago. I read an article, I think it must have been in a psychology journal, where they surveyed psychiatrists and psychologists about what do they read. And even though our endpoint, our goals are the same, in this article, we don't read each other's journals.
That's amazing. So, by the way, I could tell you that the therapists and psychiatrists don't talk on the same patient either. They don't communicate on the same, if they're not in the same office.
Almost
they're not
never.
in the same office. Yeah,
Almost never.
Yeah.
And I think the other part of it, because of
It seems
insurance.
so counterintuitive.
It
seems
it's amazing.
so counterintuitive.
Right, because no one thinks about taking a team approach.
Yeah.
It's easier to do inpatient because they're on the floor and you have to have rounds, you have to have team meetings and
and you can work with nursing staff, and the family.
Yeah, right.
But on an outpatient basis, and some of this is also, I think, really driven by insurance.
Yes, of course. They don't pay psychiatrists to do talk.
Right. So if you've got 10 minutes, 15 minutes with a psychiatrist, all they can really do is say, how are your symptoms and are you having side effects?
Side effects,
and you're gone.
Right. You go.
So what am I going to, in a way, what am I collaborating?
Right.
Sure.
Now, I might send a letter saying, hey, listen, I saw this,
Right.
I hear this, I'd like you to take this into consideration when you're working with the medication. Here's a diagnostic issue that I know this patient did not bring up with you. And this might be why the medication isn't, because you're addressing maybe the wrong problem, or it's a different medication. Or, hey, by the way, you know what? They've already been on 2-3 SSRIs. Stop.
Right.
With the SSRIs already, and it's not doing anything. So let's see through therapy, can we help them get off the SSRIs? Because I'll tell people a lot of times, I cannot make you happy. I cannot help you get happy if you've got side effects from SSRIs that decrease your motivation, that sap your sex drive or your ability to have sex.
Because it helps you connect, and that's exactly what we run into. And Vanessa, I talked about this. We're putting kids on earlier, and SSRIs very early, but preteens, and then they never understand their libido. They never understand their energy. They never understand a lot of stuff because if you take away the depression, anxiety, unfortunately, you take away some of the positive stuff, the goal setting, and some of the energy to be driven. Because if you're too chilled, you're not motivated, and so you need a little bit of edge to do some of these things.
Right.
And it removes that edge.
So I think about the SSRIs as kind of splinting emotions. Right. So we'll splint it like a finger. We'll splint it so you don't get depressed. But when you splint it, you give up the upside. Yeah. And so people also then have to understand because there's an action bias for physicians. There's an action bias for patients. If I come in and I say I'm depressed, there's an action bias. Do something.
Right.
As opposed to saying, you know what, that's a normal reaction.
Right.
Give it 6 months. Go to therapy, do something without the medicine. And if it's still not working, if you're still not well, come back. But there's this bias to do something.
Always.
When a lot of human emotion is natural. It's you're supposed to experience sadness every once in a while. It's part of the human condition.
Right. That's one of the problems we hear about from medicines is it's too blunting. I can't cry at a funeral. I can't laugh at a movie. That I'm not as depressed or anxious anymore, but I don't feel anything else either. And that's whether it's sexual or emotional. And that's very artificial. Unfortunately, you're right.
And so as a psychologist, I have a PhD and I have an MD. I'm in a very difficult position to say to a physician, hey, listen, the medication, this is your wheelhouse. I'm talking outside of my wheelhouse. I think something needs to be done here. First of all, more times than I'm not comfortable.
Yeah,
Of course.
Taking that,
Yeah.
taking that position. I'll talk to the patient, say, they're like, well, I don't have any motivation. I can't have sex. And it's like, these are side effects
Right.
that you need to talk to your doctor about, because a lot of people don't realize that the lack of motivation or the emotional blunting are side effects.
Right.
Right. So a lot of physicians will take it as to mean that you need more medicine because you sound just as depressed, if not, so it has not helped. You're still without ahedonic or hypohedonic. You don't get pleasure from doing things that should give you pleasure, etc. So some people will just say, well, you must still be depressed. That means jack up your dose or add something else.
Add something else
or give you a benzo or whatever it is. And benzodiazepines are probably a big no-no for you. They really blunt everything. Alcohol and benzos are kind of blunt. Also, you don't know what you're working with, and
the only time I'm like, hey, look, benzo's gonna be really, really helpful if you got a flying phobia.
Sure.
Oh, yes.
Right. It's a short term. We know exactly why are you.
Exactly.
Because after TWA, when they were here, they used to run a fear of flying program. You could send people. They'd fly you to and from Chicago, to and from Kansas City.
Really? Some exposure therapy. I love it.
Yeah, but when TWA left, that whole ability to do this kind of exposure-based treatment with an airline went away with it.
I've never heard of this. This is very cool.
Yeah, so now it's like, look, just dose up.
Yeah.
Take it a day or two before as you're getting anxious. Take it, follow your doctor's instructions. If you sleep on the flight, that's fine. But, you're only going to get, and this would be on the physician, just get a limited number of pills.
Yeah, exactly.
Don't give them a 90-day supply of benzodiazepine. So there are uses. Because remember, when they first came out, just like opioids, they're meant for a brief.
Everything. Sleep medicines, everything had a brief. And somehow we twisted it into decades of continued Ambien and Xanax. Right.
So, I have nothing against the medications if they're working. It's just, in terms of the collaboration, there's really very little. And I think with COVID, increased that isolation between everybody. Because I work out of my home now.
Right.
It's all telehealth. I get no interaction with other professionals. So that just made the collaborative process even more difficult.
Yes.
Unless you have like a friendly relationship.
Sure. Yeah.
With another physician. It's like, hey, by the way, this is what's going on. But you might call them on a Saturday.
Right.
Or, I'll go out for happy hour with, for drinks with another doctor.
Right.
Like, by the way, let's talk about these people over drinks.
Yeah,
which
that's
is
not quite a professional setting. Yeah. So,
but it's the only setting sometimes that we have now to actually have a sit down and spend 1 or 2 hours talking about patients, not, hey, do you have 10 minutes between patients?
Right.
And I talked to you just before this. This is what happened when we got hospice, good people, blah, blah, blah. I have a relative who's a hospitalist, but it segregated physicians from each other because they didn't have to come to a common place, a hospital or the doctor's lounge, or see each other in the hallway. All these interactions that are non-formal, you're not at a meeting, not at a grand rounds, are a big deal in terms of understanding patients, getting more information, checking yourself, checking your knowledge, kind of these curbsides and stuff like that. All that stuff is very important.
Just being able to sit in the doctor's lounge, with other specialists, like just, hey, what's going on? And sharing ideas that did you hear about this? Did you hear about this? What's going on? So just because that's a social context.
It is very big. It's a big deal. Yeah, I learned cardiology, nephrology. Whenever you listen to, whenever you're a therapist and psychiatrist, you got a constellation of opinions.
Absolutely. So I know that you mentioned we've referenced a couple of times exposure therapy and CBT, cognitive behavioral therapy. Are there any other therapy modalities that you like to employ? Are you interested in any other specific ones? Help our listeners kind of understand. It seems like you have a very practical and effective model for therapy. So I want our listeners to hear what techniques go into that as well.
Right. Okay. So the practical part, talking about my career, I also spent 14 years as a financial advisor.
I'll do it.
Right. Well. So one of the things that being a financial advisor taught me was that the client should always expect from you some kind of result or return.
Yes. Yes.
I didn't get that from graduate school.
Heck no.
It was like, if you lose money or things don't go right, you're fired.
Yeah.
So there was always this idea, I have to always not prove myself, but always perform that there's always an expectation.
Yes.
Right.
But
Good goal.
when you're
provide a return.
Yeah.
to provide a return.
Yeah.
But you don't
bottom
get
line.
that when
Right.
you're in graduate school or in training. No one says your patients expect you
Right.
to help them
Get better.
and get better.
And stay better, right?
So, look, I'm a much better therapist than I was a financial advisor. And I think that's important because I like doing this way better
Right.
than being a financial advisor. But I did learn this idea that people should expect from me help,
Yeah.
which means I can't just sit back and listen to your problems.
Right.
So the cognitive behavioral model works for me because there's a logic behind it. If you think this way, this is probably the resulting behavior.
Right.
If you do these behaviors, it's going to reinforce this way of thinking. And if I can tell people, hey, do this, not that,
Right.
and really emphasize that, in a cognitive behavioral model, that's, a big piece of it. So I really like that because there's actionable
Right.
things that you can do. But along with that, a lot of people talk about like dialectical behavior therapy,
DBT,
which
right.
was really developed for borderline personality disorder.
Right.
But I think more people are using dialectical behavior
Yes.
therapy for multiple problems,
That's right.
which is really more, I think, my understanding is, how do you cope with these ongoing
Right.
flurry
Exactly.
of emotions?
Right.
And so there is a lot of homework, but
Yes.
it really is to cope with a chronic problem that is very, very difficult to treat in traditional psychotherapy. So that's very action oriented. I just, I never, working with borderline personality, it's just a very tough person, population that I never really felt. It was too much for
Sure.
me. It
Yep.
didn't fit my personality.
Most therapists, psychiatrists already say the exact same thing.
It's really hard.
Yeah.
So, God bless those
Right.
people who are
Right.
working with
Yeah.
borderline personality disorder or eating disorders. Acceptance and commitment therapy. Being to accept this is how I certain things and be okay with it, acknowledge it. And I think also part of my thoughts about therapy have also changed as I've gotten more involved in the psychedelic community.
Right.
Would you speak about that? We talked about different types of therapies, and you talked about exposure and response, and CBT, and acceptance and commitment therapy. So, would you talk a little bit about this? What you kind of come to in the last? I guess you got your certification for. Would you talk
For
about
psychedelic
please.
assisted psychotherapy. So there's a lot of push. People read a lot in the popular press about the use of psychedelics for mental health purposes. So my exposure to that was kind of at a life-changing event. I mentioned, I went into cardiac arrest, and I was like, man, after that, I was like, I probably need to start rethinking how I live, and including my practice, because I was seeing a lot. When I was at behavioral medicine, I was seeing a lot of people every week, and I felt like I got to do something differently.
Yes, yes.
And I attended a trauma conference where it was the first time I had heard about using psychedelics to treat trauma.
An emotional trauma. Emotional trauma. Right. Yeah.
But they presented the science behind it. It wasn't just like, hey, let's just take psychedelics.
Right.
They presented the science behind why it works. I was like, holy cow.
It's a big deal.
I can get these people better, faster, more durably. With this, I was like, I'm in. So it was like for me, it kind of rejuvenated my interest in psychotherapy.
Yeah. Right.
And I felt, I was like, oh my God, at this point, the tail end of my career, to be at the cutting edge of a technology or an approach to psychotherapy, I feel blessed to be in the right place at the right time to hear it in that moment. And so, yes, I went and I got a certification in psychedelic assisted psychotherapy. The training, because of legal issues, our training is on ketamine, and I think for most training programs is using ketamine as a psychedelic.
Kind of psychedelic hallucinogenic legal one in the United States right now, right?
Which it's not technically a psychedelic, right? It's a dissociative anesthetic, but similar effects on the body.
People will have a psychedelic experience on ketamine, just like MDMA, not really a psychedelic. It's an empathogen, but is really being studied in combat trauma, through a multi-site
Can you name this? Because can we talk to kind of define what a psychedelic is and put out some names and acronym, whatever, so that people understand kind of the field that we're talking about? Because people read about it and hear about it, but there's no framework or context. So what had happened? So this is way back in the 50s and 60s. They were exploring psychedelics for all sorts of things, and then it got squashed back in the Nixon era whenever they got scheduled. And the Drug Enforcement Agency scheduled as Schedule 1, which means addictive potential without any therapeutic benefit, and then it squashed for official research for decades. And so can you tell me, I just kind of did the superficial, could you tell us about that, please, and how we got here?
So, psychedelics, plant medicine, has been used by indigenous people all over the world for hundreds or thousands of years.
Thousands.
So it's not like this is new.
Right.
It's just new in the West.
Right.
So there's plenty of history behind the use. LSD was first discovered in, I believe, 1948 through a researcher at Sandoz Labs. And from that, it was at one point up until the early 60s the most researched psychiatric medication in the world, using LSD as a psychotomimetic. Psychotomimetic. So that LSD would produce psychotic symptoms similar to schizophrenia. So the idea is we'll use LSD as a way to study schizophrenia.
Right.
Turns out, though, that the psychedelic experience on LSD has nothing to do with schizophrenia. But it was still being researched for things like, depression. But then it went from researching it for depression. Then the artist community started getting involved. Engineers, software engineers for creativity. So LSD took on this whole route from let's study it as a way of studying psychiatric illness to can we increase creativity?
Mind expansion.
Can we increase mind expansion and peacefulness? Then it became a social issue. As people started saying, well, maybe we can use this. Well, I'll say then the military got a hold of it to say, can we disable people using things like LSD? Then the CIA got a hold of it and say, well, can we use this as an interrogation or mind control medication?
Weaponize it,
and then we get into the social aspect in the 60s and the flower children, the hippies. And that's really when it got out of the labs, and the same thing with MDMA when it got out of the lab and into the clubs, that it got shut down. The thing is these the medications that we're talking about. So it's like, what are we talking about? LSD was the first one that we're using in the West. Magic mushrooms or psilocybin. DMT, dimethyltryptamine, which is a naturally occurring
it's in our brains already.
Psychedelic that is produced in the pineal gland, which also produces melatonin. We have no idea why.
That's very interesting.
Right? It's like we have an endocannabinoid system. We just figured that out in the 80s. And then find out that, we've got anandamide and 2-AG, which are endogenous cannabinoids. So we've got a whole system set up to receive cannabis. So then we've got DMT, 5-MeO DMT, is people that like the toad venom.
I've not heard of that. What do they call it again?
5-MeO DMT. So it's a different molecular structure than DMT, but it comes from the Sonoran desert toad. But they're synthesizing it because they don't. People are going and catching these toads. It's a very small environment that they live in. So you have those are the kind of like the traditional in ayahuasca, but the active ingredient in ayahuasca is DMT. Then you've got the lysergamides, which is really just LSD and all the derivatives, and then the phenyl. I forget the technical name, but things like mescaline. That comes from peyote or the San Pedro cactus. So these are the primary psychedelics, but the ones that are really being researched are the serotonergic tryptamine-based, like magic mushrooms and LSD and DMT. Those are really the one people are talking about psychedelic. That's really what we're talking about.
The 5-H2A receptor. These are when you say serotonergic. That's what the receptors we think that's hitting.
So when we talk about SSRIs like Prozac, Paxil, they act on the 5-HT1A receptor. The 2A receptors for the psychedelics. So they work on different. So it's still serotonin. Just different receptors. One is activating. So with the psychedelics, it's activating. Let's approach your problem. Let's address your problem. Or the 1A, which is let's suppress your reaction.
That's very interesting.
So it's a whole different mechanism of action.
Interesting.
So using the psychedelics allows people to approach the problem better with a full range of emotion. rather than suppressing an emotional reaction.
So therefore, the sets and settings. So can you talk about that? The drug dose mindset and setting, and then integration. Could you we'll close out with that because that's fascinating.
Right.
Because that's very powerful. I tell people Prozac doesn't matter if you slept or ate, whatever. Taking your Prozac, you feel the same if you've been on it regularly. If you do any of the psychedelics, ketamine in our case, it's a big difference in how if you didn't sleep or eat or you just were in a fight with your spouse before you came in to get your ketamine, it's a big difference in your experience.
So when you're talking about psychotherapy and different ways of doing psychotherapy, so one way of looking at it is like, I'll give you an SSRI. It's a passive approach to medicine. I'm going to take this and I'm going to wait for it to do its business.
Sure. Okay.
If I take psychedelics, I tell people it's a partnership.
Yeah.
Yes.
You have to work with the mushrooms. You work with the LSD. You work with the peyote. You work with it. Because you might say, this is what I want out of it. And all someone's like, I know it sounds kind of weird, but you might think this is what you want, but the medicine might have something very different in mind for you. So it's an active partnership. So while my therapeutic approach is active, I tell people this is not a passive take it and wait. So when people are reading about psychedelics, my thing is like, don't go out and just take a handful of psychedelics.
No, please don't.
Because if that were the therapeutic benefit, then anybody who dropped acid or mushrooms at a music festival would be great.
Would be feeling great.
Right?
Yeah,
but that's not the case.
No.
So we refer to set and setting. Set refers to the mindset. What's the mindset that you're going into this with? So I'll spend time, 3 or 4 sessions before the actual experience to say, what is it? How do you want to use?
Right. What's your intention?
What's your intention? How do you want to use this process and have them journaling and get their mindset moving in that direction? Then they'll do, whether it's microdosing, small doses over a couple of weeks or a macro dose. Then when they're done, it's like, how do we integrate the information? Because these experiences, especially in a big macro dose, can be very confusing. They might not have any direct, or it might be hard to find, a direct one-to-one link between your intention and what did you come up with. So the integration part is how do we make sense of that experience.
Right. And sort of digest it into useful cognitive bits, right?
Yeah. And this is so foreign to almost probably therapists, psychiatrists, everybody except somebody who's focused in the type of therapy that you're just talking about. Yeah, it's so foreign. It's such a foreign concept.
Right. And the thing is, for a lot of people, you can we all experience periods of sadness. We all experience periods of anxiety. But these experiences on psychedelics are so unfamiliar. There is no way.
Yeah.
So sometimes instead of journaling, it's like, you're just going to have to draw, instead of journaling, it's like get some colored pencils, get some markers, because you might not be able to describe in words. So we're going to have you do some artwork or some other ways of integrating that information.
And different psychedelics, different doses give you totally different experiences and length of experiences and
DMT is interesting because it's like a 15-minute.
Very short.
And one of the real cool things that I've been reading about is the research being done for things on stroke. So how do you take advantage of the neuroplasticity and synaptogenesis for a stroke victim? Yeah. And since a DMT trip is only 15 minutes long, can we use that not for the psychedelic part, but for the synaptogenesis? The synaptogenesis.
So what Larry's talking about is this idea that brain connections between neurons are destroyed when depression and stroke in this case, and that we can regenerate some of these synapses or connections that help us with everything from movement to memory to speech. Yeah. Very powerful stuff.
Everyone has a slightly different duration, a different impact, but a lot of that again is going to be impacted by the set. Yeah. Mindset. And so if you look at indigenous tribes, their set using psychedelics completely different because they grow up with it as part of their culture.
Right, it's very cultural.
You don't hear a lot of people complaining about bad trips in the indigenous community because it's part of their culture. Right. But we'll hear it pretty frequently because it's not really part of our culture.
No. Absolutely. Well, I think that's pretty much all we have time for today. I think that was a great foreshadowing to the next time that you join us, Larry.
We're lassoing again.
Yeah, absolutely.
This has been great.
It's just such an exciting, frontier. I'm so grateful that you've been able to come to this at your career and that you can, share it with us as well. Yes. Certainly, at the Ketamine Clinic, we have a lot of interest in seeing how this can help people even more. So we're so thankful for your time today.
Thank you for your experience, sharing all the experience well before you ever got into psychedelics and ketamine, helping people more quickly that way. So we appreciate your time and your this morning, and thank you. And we want to see you again. I appreciate it.
I'll be back.
Thank you.
As long as the invitation's open.
Thanks, Dr. Shapiro.
All right. Thanks, everybody, for listening today. As always, if you want to get involved with the pod, you can send us questions or feedback at our email address, at notyourdocpod@gmail.com. You can also check out our website, notyourdoc.com. That'll have, links to Dr. Tadros' blog, as well as all of the podcast episodes. You can reach us that way as well. Thanks again, Dr. Tadros, Dr. Shapiro, Seth. I'm Vanessa. We'll see you again next time. Thank you.
Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.